Okay, Chapter 8. Where are we? Where do we work? We're everywhere, and this chapter does a really good job of showing you all the places that mental health practices are at. It starts off talking about the continuum of mental health care. When you talk about the minimum of care, you can think of it like a ladder. So like you've got the first from a ladder all the way to the top. And so the diagram that it provides you on page 176 starts with least restrictive to most restrictive treatment. And it makes a note that obviously the least restrictive care that you have, the cheaper the cost it is to society. So the higher up on the rim of the ladder, not only is it more restrictive in care, which means it takes away rights of the client, but also it becomes the most expensive types of care. And so if you think about, again, the realms of a ladder, then you can think about like preventative care would be that first realm because we can provide a lot of care preventative wise to a lot of people with no restrictions on their person. They're just getting the information, they're getting it. We're not restricting them in any way. As you move up the realm of the ladder, you get into things like case management, you get into things like case management, outpatient services, individual therapy, family therapy, group psychoeducational groups, all of these type of make an appointment, go to this type realm. And then you have what is considered more restrictive than that would be very high risk, high level, severe mental illness type treatments that could include school-based services where you have a clinician in the school with you, a clinician that comes to your home that provides services to your family. These are higher level services because you have to be at risk factors and you have to require to provide sometimes 10 to 15 hours a week in these services to get them. And those can obviously lead to more restrictive care above that, which is like inpatient to hospitalization to even institutionalized, being the highest realm of that ladder. One of the issues with the realms of the ladder is a lot of people find out about programs or they know of programs that they like or they want, and they want to kind of come in the middle of the ladder. For example, there is an issue for people to come in and want services in the home-based services for high-risk youth, or services in the school system if they've never even had a case manager or outpatient therapy to try because they haven't climbed the appropriate levels of that service. So you're going in at a very expensive service when you don't know if more of the minimum services would have actually prevented any issues. This has really put a high cost on mental health, and they've been trying really hard to put restrictions on it. And one of the issues, if you think about it in everything else, like if you have a heart condition or something like that, you probably went, unless you just end up in the ER, if you have a condition, you probably went to your primary care physician, and then that primary care physician referred you to the specialist that you needed. It's the same setup for this, but people are trying to go straight to the neurologist or straight to, the surgeon without going through the primary care type services. So that is an issue with the finances, and the higher up on that level you get, the more expensive it is. But also, the higher up on that level that you get, when they talk about least restrictive, that means that the client has to participate in things. They lose the ability to have all of their freedoms. If you're in residential or you're institutionalized, you don't have the same freedoms of somebody that lives on their own. So every one of those, they lose freedoms as well. And that's the continuum of care. The chapter, as it talks about where we work and how we work with different population, it goes over how homelessness is defined, homelessness and addiction, the transient group, and how other groups can overlap with homeless populations. And basically, it kind of gives you like a brief overview of how different populations, even though they look similar in certain circumstances like homelessness, how their needs are very much different. So it starts off with defining homelessness, which the word itself is absence of a home, not having your own place. But in a mental health mentality, when we think about someone not being in their own place, we also recognize that, one, they don't have their own home. They don't have a consistent place to be. They don't have the resources that they need. They don't have the support system that they need. And this causes so many more complications for getting them support systems if they don't have anything. For example, if you had someone that was homeless and you were getting them a food box, they don't have a refrigerator to keep certain items in. Like even something like that has to be a thought. So when it talks about homelessness and how it overlaps with other populations, you've got homelessness with addiction, homelessness with youth, and it talks about how so much of our youth, the risks go up after 30 days of homelessness, of them being in some type of sex trade or sex trafficking type position due to homelessness. Homelessness and the transient group not having a place to be. So this is how it's going to break it down. There's a lot of programs that will not or are not designed to help people because they're homelessness, because they can't even fill out the correct paperwork, because they can't fill out an address, or they may not have or know their social or have a phone, different things like that. Some areas have tried to work with the ability to not have certain requirements, but it still makes it hard, and sometimes people don't work with those populations because they just believe it's just too hard and you're not going to make a difference, or that people are where they want to be and there's nothing that can help them. If you are working with a homeless population on mental health, you have to accept the fact that connecting them to services is extremely difficult. And you have to figure out ways to make services work for them in a different way than you would with someone that was not homeless. Case management is a really good service for individuals in this population because it's a whole lot of external advocating and resource gathering. So case management is always really good. There are programs designed to help people get back on their feet. When it comes to the models of service delivery, there's a bunch of different models out there. Some of them they found did not work for the style that they were set up for the homeless population. So there has been a lot of redesigning these training programs, placement programs, specifically with homeless populations in mind, like Wraparound Services Act, which is assertive community treatment. And these are designed to meet the needs of the client holistically, and that allows for a little more flexibility in how we are managing the client's needs and the resources that they need. So if there is homelessness, addiction, mental health, other mental health needs, all of that can be addressed. When we look at co-occurring mental disorders, so having a diagnosis as well as having an addiction disorder, the comorbidity is extremely high. And one of the things that I think a person needs to understand right off top is there's a lot of people that may come in this field and think, I don't want to work with addiction, or I don't think I would like that. No matter what field that you get into here, you're going to hit addiction in one way or the other. If you're working with youth, you're going to deal with it from the parent side, the providers of this child. Maybe the kids were taken from the family because of addiction. Maybe they're trying to reunify and there's an addiction that maybe the kid has the addiction at a very young age, all the way up to geriatrics. So no matter what population you're serving, you're going to have some knowledge and understanding of addiction. So even if that's a field that you're trying to avoid or not be so involved in, at least take note in those courses, because you cannot avoid it in mental health. It's there. 2/3 of people with addiction disorders also have a mental illness. So for every 3 people, 2 are going to have a mental disorder. You're going to find it in some way. Also, depending on what you're reading and how old it is, you need to know that there's some interchangeable words here. You're going to hear co-occurring, comorbidity, dual diagnosis, dual disorders. All those are interchangeable words. It's just terms that have changed due to trends over the time. A lot of times when people get sober, there's this realization that I have depression or I have anxiety or PTSD, some trauma, whatever the mental health issue concerns are. And a lot of times there is a lot of energy trying to put forth, did the addiction begin because this person was self-medicating? Don't get caught up in the chicken and the egg. Where you are with that person is them trying to combat addiction and deal with their current symptoms. It's not going to benefit the client a great deal to spend so much time just trying to figure out what caused who or who caused what, as much as it is of working on what do we do now. Your textbook talks about putting people in categories of levels of complexity, of how difficult their co-occurring disorder is. It starts on the last paragraph on page 182. Low severity mental illness, low severity substance use disorder, severe persistent mental illness, low severity substance disorder, low severity mental illness, high severity substance disorder, and severe persistent mental illness, high severe substance disorder. So let's just make that common sense. Dual diagnosis, 2, addiction, mental illness. It can be both low, one high, one not high, or both high. That's the 4 categories. So obviously, when you're dealing with a person and you're dealing with their complexities, you can have addiction, you can have mental health, and you can have medical disorders. And these can absolutely all impact each other. So one of the ways that mental health people provide services is through assessment and diagnosing, which we've talked about a little bit already. And when we are diagnosing dual disorders, sometimes we don't always have all the facts with us up front, and sometimes we have to get a lot of that by history or report. And so a lot of times we might be putting something in someone's chart that is a prior diagnosis. And this is how they may say that they were previously diagnosed with bipolar or an addiction. because if somebody comes in and they're highly intoxicated by some substance, they're not probably going to have current symptoms of anxiety or depression at that moment, which is why we would go on history. Also, in that discussion of the person that you're assessing, you want to assess what they feel their stage of change is. That's a very important factor in how treatment's going to go forth, is if they feel like there is a problem, not a problem, not aware of the need to make any changes. So the stage of change, doing an ASAM, is extremely big, and you'll learn more about that in other courses as well. There's definitely different programs that work with dual diagnosis now, such as psychiatric hospitals, some 12-step programs that are modified to meet the needs of the mental illness as well, therapy, and different types of specific evidence-based treatment. Depending on where you work, those treatments will vary depending on what your agency is delivering to clients. That most agencies have their own style and their own treatment plan. Maybe they've wrote a grant to deliver services a certain way. Maybe it's a hospital that has a specific program and guidelines that you follow. So those are going to vary just depending on where you are actually working, whether it's an inpatient, outpatient type facility. Again, if it is with corrections, you're going to have very specific things that you can or cannot do with inmates. There's going to be a focus on treatment that reduces recidivism, because that is just something that right now recidivism is very high. There is new services that you see trying to help people transition back into communities, transition back in with support, transition back in with services, so that can be reduced. As far as somebody that's worked in the field, one of the things that I've always found extremely difficult is somebody that is trying really hard to get back to some type of normalcy after being in the system, and having a felony is trying to find a job. And so I know that there's a lot of things going on working to try to keep felonies from being such a big impact on hiring people. But that's really a big issue for people that are actually trying to work. And so they've got a probation officer fussing at them over trying to get a job, and then they've got employers not hiring them over having a felony. And they've even had people that got fired because the employer found out that they lied on the application about a felony after the fact, when they were actually a pretty good employee. So it's just a lot of stuff you got to think about there. There are more mental health people in jails and prisons now than there ever has been. That has been something that has been increasing over the last decade. And that's really good to know that they're trying to get programs in there to prepare people and to provide support and to help with that transition back into the communities. We've talked a little bit about CACREP, and this is just basically talking about some more services that we are involved in, which is regarding crisis and trauma, disaster response, and emergency management. And so whether it is a traumatic event by nature, or a traumatic event by a person, we are often called on the lines to, one, provide support to the victims, to firefighters, first aid, first responders, period, to provide support to those people that are first responders, and not just the first responders themselves, but also to those first responders' families, because Think about the people at home knowing that their loved ones are on the front lines. So when it comes to crisis response, disaster response, we provide services to the victims, the people that are first responders, and the family and the community that support those people. And when we're dealing with a disaster or a traumatic event as a multitude, we look at first that initial impact, how that person is doing, do like that debriefing. They have to take time and process it. And there is times that after someone has had some time, there becomes to be some post-trauma that has to be worked with as well. There's a movie that has Forest Whitaker and Dakota Fanning. I think it's called Fragmented. But it's a really good movie. It has a trauma event in there, and it shows how 7 people, especially if you're interested in trauma, this is a good movie to watch. It shows how 7 people so totally dealt with a traumatic event and how it looks different for each one of them. So we talked about debriefing, and there's specific things that you want to do, obviously, in a debriefing is to decrease any psychological impact that it's having, allow people to work through it, decrease the chances it's going to turn into a PTSD trauma type disorder, and provide screening to go ahead and get referrals into like a PTSD trauma diagnosis. It talks on page 189 the 7 stages: introduction stage, fact, thought, reactions, symptoms, teaching, and re-entry. This is just one program, the way that you would go through a debriefing of getting introducing who you are, gathering the information, finding out what you need to do, seeing what's going on, providing some quick down and dirty coping skills that might be all somebody needs, and then sending them back out into the world. The next section talks about psychological first aid, and it has 8 stages: contact and engagement, safety and comfort, stabilization, information gathering, practical assistance, connection with social supports, information on coping support, linkage with collaborative services. So if you look at 7, 8, there's not a lot of difference. It's that are very much synonyms for other things. It's just one program uses this word, one program uses this word. It's still the same difference. You're still getting in there with the person, getting to know what's going on, figuring it out, helping immediately where you can, and either sending them back out or sending them somewhere else for more intensive services. But your goal is to have that initial screening that comes in, impacts, assesses the situation. Does this need a Band-Aid or does this need surgery in the mental health world? There's a lot of services going on right now in trauma-informed care. You can get a lot of CEUs too if you get a chance to take that, and that's something that interests you. It's a growing evidence-based service. It teaches a lot of coping skills, ways to do breathing techniques for trauma victims, ways to stay grounded. So if that's something you like, and it allows you to come at a trauma from a perspective of empowering the client and giving them the control of their symptoms. You might see in agencies where you work that they talk about having an emergency management system or an EMS protocol. And basically this is a group of people that if something happens, they know exactly what their roles are, what the protocol is, and how that gets called out. So if it's something that happens in the community, they know exactly who's going where, what everybody's role is, and how to respond to a disaster in that area, whether it's inside the agency or in the community. So it's their plan, their EMS plan. Now, when we work as mental health providers, when we work as private practice, our responsibilities to the community decrease unless we've automatically signed up for those. We don't offer a lot of things often, like case management, psychoeducational services, things that maybe other agencies can offer because they get grant or state funding. So we can offer more privacy to our clients in private practice because we're not in a community mental health setting, and we have less support ourselves as a private practice therapist. It is incredibly important for us to take our own self-care very serious. There are pros and cons to everything. In private practice, you are more alone. You have less types of requirements that the state may put on you as a community mental health center. However, you have less support, you have less staff, and you have to do your own billing, and you have to be more responsible for your own liabilities, somebody covering when you're not available, all of those things. Counselors that work in the substance abuse treatment programs definitely are at high risk for burnout. There is a lot of turnover, low success rates. In substance use treatment programs, the mental health workers there are at really high risk of burnout because of the style of delivery. A lot of mandated clients, people not wanting to be there, people coming in and out of services, lower risk of success in some cases, seeing people relapse over and over again. Those type of things can affect the clinician and cause a lot of burnout risks. There definitely is an increase of mental health counselors in colleges and universities, which is nice to see as well. We've definitely got our foots into a lot of different types of places. Large evidence of working with horses, equine therapy, especially with certain populations. I have seen equine therapy work for high-risk youth and children with sensory or communication difficulties, like kids that are on the spectrum. Home-based services, we talked about that a little bit earlier on the levels of care. Home-based services can be at home or at school. As a clinician, home-based services are nice because you have a small caseload, because if you're having to travel to people's homes or spend a large amount of time with the child or the family, then you can't have a really big caseload because there's only so many hours in the day. So you might only have a caseload of 5 or 6 people, and that's definitely a benefit. You get to really know those people because you're in their homes, you're in their lives, and that's something that you might not get in an office setting. The downside is if you're doing home-based services, it's really hard to have any evenings because you're usually in someone else's home in the evening. So a lot of times you have to wait for kids to get out of school to go to do their home visits, or people to get off work. So a lot of times, depending on the type of service that you're providing, sometimes people leave home-based service jobs just because they can no longer work all evening hours. Anytime that we're working with mental health, though, there's the chance that we're going to be working with other providers and other medical professionals, no matter what. So not just home-based. A lot of your doctor's offices, your primary health care setting clinics, they'll have their own labs, their own mental health providers, and everything like that. So that's really something that's up and coming. Now, what you may not know is the reason that they want to do this is they actually get better reimbursement benefits the more integrated their services are, just so you know. And it does provide better holistic care when all the providers are in the same charts, and you don't have to go request information, or you don't have to be afraid that you're not going to get a response from a service provider. It's kind of nice when it's all in one system. When we work in a integrated system, so there's doctors there, there's nurses there, there's a lab there, and we're the mental health people there, then we work in a facility where we can not only see if prescribers prescribe a medication, but when we talk to that client and we talk about their symptoms or how their depression's doing, then that provider also has immediate access to that client's notes too. So how it all works under that umbrella can be more smooth than it would be if it was 4 or 5 agencies trying to coordinate services. So there's definitely some bonuses to working in a primary health care center. It doesn't look a whole lot different as far as what you would primarily do with creating your treatment plan, working on the needs of the client, addressing their symptoms. Just like in any mental health services, you can get a variety of patients with different issues. When we look at this as a together, we are in community-based, we are in inpatient, outpatient, we are in emergency services, crisis situations, we are in consultation, education. We're everywhere because our mental health is impacted everywhere. We are in many aspects of life because our mental health is impacted by many aspects of our lives. We are complex human beings. So whether it's school, work, education, integrated agencies, institutions, mental health is part of where we are, even if we're on the streets. So that is a little bit of overview of all the different places mental health people work. And that concludes Chapter 8.